glucose is recovered, you can give me insulin again. So this was introduced, was a relatively popular tool, particularly for those who had a significant amount of hypoglycemia. Some of it was barely symptomatic, some of it was very symptomatic, and some of it was of the severe form that often leads to coma and seizure. Once we got to stopping at a threshold, why wait till you get to the threshold? We can predict when you're going to get there. These algorithms are really quite brilliant. And we can stop before you get there, so we can stop you at 100 and turn that curve around so you never get into the hypoglycemic range at all. So with the suspending at a low glucose value, we mitigate the exposure to hypoglycemia. Now with the predictive low glucose management, we can actually prevent hypoglycemia. But that was all about delivering insulin, stopping insulin. Where the real crux came was, can we actually, with that algorithm, deliver insulin as well? So every 5 minutes, the device can look at what's the glucose value, where was it, where it's projected to be, how much insulin is on board that got me there, and how sensitive was I to that insulin that was just delivered, and do a calculation to determine how much to give. Another 5 minutes goes by, does the sum calculation again to determine how much to deliver. So every 5 minutes, it's assessing how much insulin should be delivered to keep in that target range of 70 to 180 and to mitigate and prevent those glycemic excursions on the high and low side. Now, the great news is that this has improved outcomes. So this was approved by the FDA in a rather fast track. There's other companies coming out now with similar devices, algorithm a little bit different, CGM, the continuous glucose monitor, a little different, the pump a little bit different, but I will predict that likely they're all going to have pretty close to the same outcome. That we are able to improve glycemic outcomes, mitigate hypoglycemia, reduce diabetic ketoacidosis, and improve A1C with this automation of insulin delivery. Right now, it only automates basal insulin, and the patient has to determine what they're going to do around their meals and their corrections. The next iteration will be to give automated bolus around correction, and the real trick will be how to pre-give the meal insulin, because there's such a lag between when we have the insulin delivered by the device and when it's actually absorbed into the body and affected. There's about a 15-minute delay. So right now the patient is asked to do a bolus before they eat by 15 minutes. And we think we may have some strategies of understanding patient behavior, patient patterns, using a lot of other potential metrics to be able to automate it all and to develop what the patients really want is what they call an artificial pancreas. And then all they have to do is wear devices, go on their way, and theoretically keep your glucose values correct. There'll still be the patient who doesn't want to wear devices at all, so we will implant the sensor. That's already a reality. We can, at some point, there are the consideration of implanting the pump as well. Maybe these are 10 years away while we wait for the cure for type 1 diabetes or type 2 diabetes requiring intensive insulin therapy. Maybe in the future one could conceive that this could be a hospital-based product where somebody comes in, why have a nurse and a doctor and a set of orders and a bunch of sheets when the device could do it all on its own. So I just want to show you a few of these sensors. This is what they look like, lots of trends. You know, we were hoping we could put the sensor in the contact lens. I don't know if you were aware that this was a big effort. It has now been stopped. Doesn't seem like the ocular fluid moves around as much, but these are external ones. That little, I don't know if I can point it over here, this guy, this is the implanted sensor, and therefore the burden on the patient is much less. This is something that's kind of intermediary. It's called the Libre System. It's not sending continuous glucose information, but you can just wave something over it and it can give you the number, and then you can upload the data. All of these have the ability to upload the data into a system, and of course now AI is looking to be able to interpret all that data and give recommendations to patients. Probably one of the other big benefits of all of this, particularly in the pediatric world, is that it's available in the cloud. So I could be here, I could have my phone here, and I could follow my 100 patients on my phone with alerts. Now, I'm not suggesting that that's what doctors or healthcare providers should do, but that's certainly what mothers and fathers and grandmothers and grandfathers and best friends can do, so that as travel goes, a safety backup is that somebody's sleeping in a hotel room, there's a low glucose value, you don't see something happening, you can make a phone call and help rescue somebody who is having an issue with their glucose control. And just to show you that this continuous glucose monitoring has been more beneficial than finger sticks themselves in a number of studies, the A1C reduction. The improvement in overall glycemic control is much better when that data is continuous. Now, of course, the patient has to want to wear the devices, has to be able to deal with the data if they don't have one of these automated insulin delivery devices with them. But they're just, I'm just going to quickly go, and they are now also being used in type 2 diabetes, quite a number of studies showing that for those on intensive insulin therapy in the type 2 world, that this actually makes a big difference in addition. So this is looking at the type 2 subjects with MDI with usual care, so just finger sticks, versus CGM. You can see that with the CGM, there is a more significant reduction in A1C. So there is a lot that technology has to offer patients with both type 1 and type 2 diabetes. It's a burden right now in some ways to educate the patient into how to use these optimally. But as time goes on, because all the data can be uploaded, all the data is now, there's quite a number of groups that are looking to give dashboards to clinicians, dashboards to the payer, whatever it may take to assure that if you're going to pay for technology, if you're going to think your patient is on technology, that they're actually really availing themselves of its maximal benefit. I do want to say that in the world of diabetes, it has been, an exponential increase in not only technology, but in therapeutic agents as well. I don't know if you're aware that just recently the FDA has now approved what would be considered a type 2 drug to also be used in the type 1 population. And you could argue if insulin is a type 1 drug, it obviously is used quite a bit in the type 2 population. As time goes on, as type 2 diabetes often now develops very early in adolescence and young adulthood, one can expect that those patients over time will likely have a significant burden, and we will look for ways to mitigate their poor outcome, and likely many of these individuals would be potential for using technology to improve outcome. It's an exciting world. As all of this occurs, the difference between type 1 and type 2 diabetes starts to blur more and more. What is available for one likely will be available for both, and there'll be therapeutic benefits from the highest level of insulin therapy and technology to some of the type 2 agents being used in type 1, and that at some point, we may not need to put on an statement of medical necessity what kind of diabetes somebody has, or that they have diabetes, that they're not well controlled, that they've tried this and this and this, and now we want to go to the next level, and perhaps there'll be a next level after that. So it is the opportunity, I think, for us to rethink who gets what, and how we can work, obviously education being critical, motivation probably being the most critical, and now this ability to look at a very, very big menu of options for all of our diabetes patients, and really work hard to figure out how we can optimize these kind of outcomes. I don't need to tell this group that the complications are significant, and yet, and I know I had the opportunity when I was ADA president to give many awards to people who had had type 1 diabetes 25 years, 50 years, and 75 years. The ADA gathers people in a large auditorium and invites whoever wants to come. They give them a medal. And I had 275-year duration of diabetes. So right after Banting and Best had discovered insulin, these individuals were treated. The first one kind of looked the part, amazing, almost in her late 80s. The second one defied the part. He kind of ran up onto the stage, thanked his mother, who had been gone for about 60 or so years, and then there was a woman with him. I thought it was his daughter, and he introduced her as his wife. He survived 4 of them, and there was no reason to think, as he told everybody his whole life, and I think it was a great message and one that resonates as we have more and more to offer individuals. There's no reason to think that diabetes should stop anything, as long as the education, the support, and the therapeutics and the technology is available. So I can stop now and answer any questions.
We have you on the schedule till 1, Fran.
Okay.
And then we'll move to Neal.
I thought I had 40 minutes and I started earlier. Okay.
Oh, it's
All
fine.
right. I can answer questions. I've got more slides if you want to see more slides.
Let's keep going on
Okay.
slides a little bit, and if people have questions,
All right, so
raise your hands.
here's the
please.
implanted sensor, just to show you. And all of these sensors, this is the Libre System, all of them have really good evidence that they work. I mean, the data is the data. If they're accurate enough, the data is actionable. And then we are working towards kind of, and maybe something that the world of cardiology faced a long time ago, each one of these companies has their own way to look at the data. So you could be in your clinic and you've got somebody on one system and another system and another system, and you're looking at 3 different data displays. So we've now kind of come to a consensus of what's going to be called the AGP form, and this is what it's going to look like. So you'll get over here is, and good luck explaining this to your patients, this is the median and the interquartile range, so 25 to 75, and this is usually going to be 10 to 90. All the glucose values for whatever the reporting period will fall in there. And then you'll get one of these racking and stacking, so very low, below 54, below 70, in the target range, 180 to 250, and above 250 to look at the glucose. And then the goal also is to look at some of these metrics, I'm just trying to figure out, of glucose variability. So the standard deviation and the coefficient of variation. So I've already tried to do this with my patients in my clinic and say, here's your mean, everybody understands, or your average glucose, and here's your standard deviation. So there's a failure of math education in this country, so I go like this and I go, your deviation like that. And then of course the coefficient of variation is the correction of the standard deviation for the mean glucose, because the higher the mean, the greater the standard deviation. And the goal of the groups that have come together, in particularly the type 1 world, is that we are going to teach this to our patients the way we taught them A1C, and we're not going to teach them glucometrics so they can understand this. And I think you could see here is midnight, so you come really well, come in fasting, here's breakfast, lunch, dinner, go to bed a little high, and so you can make some overall estimates of what you need to change by looking at these kind of displays.
Fran,
Yeah.
can you go back to that slide for a moment?
Sure.
So in our Los Angeles group last year, Ann Peters was talking about how different that is for each patient and how important it is for each patient to really learn the different foods that change the graph.
Well, you could say that. So you could look at, it's not just food, right? So if I don't take the right amount of insulin for the food, the same food will have a totally different outcome. If I don't take the insulin at the same time before I eat, you'll get a different outcome. If I exercise before, if I ate 2 hours before. So it is difficult. It's probably easier to do that in somebody who doesn't have diabetes, to look at what does pineapple juice do to me every time I drink pineapple juice. And there are a lot of, well, there's a drive certainly by industry itself to say maybe this is a tool for people without diabetes so they can understand their own, kind of metabolics with their food. I don't know if you really need to do that. Probably if you, ate no simple carb, you wouldn't get a big peak, and if you ate good protein and a mixed meal, you do better. So I don't necessarily agree that that's very easy. Now, people will tell you, I need more when I have ketchup. I need more, well, there's a lot of sugar in ketchup. I need more when I do X, Y, or Z. But trying to pick out and determine each individual food you're eating and try to find a pattern, it will all depend on all those other factors as well.
Can you talk about low glycemic foods, protein, vegetables, exercise, how that affects the graph?
Well, the simplest one to talk about is go drink a glass of juice and wear a CGM, and you'll see a peak in your glucose. Very early, if you don't have diabetes, you'll be back down before an hour. And just, there's a lot of glucose variability in people without diabetes. It just all corrects itself by the end of an hour. So if you, and many of us have done this, had a CGM on and, ate a bag of jelly beans, you get high glucose, and your insulin response would clear before an hour. So we always look at what, it's been the 2-hour mark, but now actually there's probably a big push to talk about the 1-hour mark, particularly for gestational diabetes. So if you add fat, it delays gastric emptying, so it could take that curve and flatten it a bit. If you have a lot of protein, so a mixed meal is usually flatter than the individual, particularly components that have a lot of sugar themselves. So if you want to drink juice, you better eat it with, maybe eggs and toast and butter would delay that peak from your juice. Yes.
Kaufman, you mentioned that artificial intelligence and machine learning seems like that could help with both development of algorithms, and maybe someday a chip that picks up that data and kind of looks at patterns and progressively gets better. Where are we in that?
So, close. So kind of, let me explain. So you could put whatever additional inputs you like. So you could certainly have an accelerometer. It's a little unclear still how to use the accelerometry data. There's a lot of controversy. So aerobic versus anaerobic and fasting versus not fasting. You could put, heart rate monitor, which might help pick up some hypo as it's occurring. You can put in a GPS. The ultimate device would be, I see you're driving into a McDonald's parking lot. I got two choices. I either front load you with a little insulin, or better yet, I cut off your credit cards. So, some of these real AI things, are looking at patterns. And you're right, most of us have, a pretty significant pattern. And particularly children, they go to school, they do the same thing, except maybe now on Tuesday and Thursday they have gym. But the machine learning can account for that. It all just happens, what happens when you're on your way to gym and you decide not to go.
Right.
So, how can they push back in insulin? Probably the most important thing for all these automated insulin delivery devices would be a much faster acting insulin. So Novo Nordisk has one that has been approved. The other companies have one as well. It is faster, so that that 15 minutes I need, maybe I only need 8 minutes now, but I still need some minutes because I'm putting it into a sub-Q depot. If we get eventually to an implanted system where you want the insulin to be delivered, would be the peritoneal space, because then it's absorbed into the portal system and shuts down the liver. So there's a lot of variables, but the machine learning is doing good, and it can certainly retrospectively analyze a lot, and pull out, this is your worst meal, this was your worst day, those kind of things. But there's stress, sleep. I mean, there's a lot of variables that go into what your glucose response is going to be like. And then, does the patient want all that is the next question. I mean, how intrusive do you want this thing actually to really be? How accepting, and how many, so one of the concepts is that the data is up in the cloud running with a virtual you up there to try to figure out the pattern, and coming down in addition to the primary algorithm, changing algorithms as they go. But I think, even the way the system is now, we probably have the opportunity in type 1 diabetes, if people would wear it all the time, could afford it all the time, and keep all the parts running, that you could probably get to a mean A1C in the low 7s, if not lower, in the adult population. And you could probably eliminate diabetic ketoacidosis. You could probably come close to eliminating severe hypoglycemia. And some of the systems will have been considered to have dual hormones, where you have glucagon in addition. So if you did get to be too low, you could recover somebody before they got into a serious issue. Yeah.
So clearly our type 1 diabetics are totally dependent on this technology. For many of us, we don't have a lot of type 1s. 85% of our diabetics are type 2 diabetics in the population. But yet our type 2 diabetics in your curve have ratcheted up that about half of them are on insulin these days just to control their sugar. So it is certainly a significant problem in a growing population of patients that's there. We've always been concerned that adding insulin as a second drug, usually after metformin, in these individuals, what does it do to cardiovascular risk? And if you look at the meta-analysis, the use of sulfonylureas and also insulin increases cardiovascular event rate by up to 36% compared to other second-line agents for it. So our concern has always been, when we're adding the insulin, which we think we need for control, what are we doing to tip them over to cardiovascular events? So my question is, do you feel that this better control of limiting the variability and reducing the hypoglycemia is a way to eliminate that 36% excess mortality and event rate associated with insulin?
So I would say it's likely very few people are going to be on sulfonylureas in the future.
No,
right.
correct.
So,
Wipe those off.
Metformin will still be first line, but then you're going to get to a DPP-4 or an SGLT2 drug or a GLP.
Right.
So if you fail in controlling glucose on those, you have only the alternative of adding insulin, and of course you could remove probably at least 2 of those other drugs at the same time. And I think the data suggests at that point that you're actually not really looking at an excess mortality anymore from insulin itself. And that, in addition, obviously keeping blood pressure and lipids equal and under control, that the benefits of glucose control are probably outweigh the risk of additional cardiovascular events. So, you know, and that takes into account that you've got to prevent hypoglycemia. So that's, you know, with this technology is the way to do it. With the CGM itself, even without automating insulin delivery, is another way to do it if the patient is motivated and educable on how to prevent hypoglycemia. Yes?
Have you looked at, when you talk about variation, have you also looked at, and for type 2s, the basal insulin variation? Because with the delivery of insulin is different, obviously, if you look at NPH versus the recombinant analogs. There's variation within the insulin molecule itself. And thus, if nothing changed day to day for a person on type 2, on basal insulin, nothing changed, diet, exercise, everything else remains constant. There's still the variation within the line because of the delivery of the insulin and the absorption of the insulin. Has that been looked at?
So you're talking about the different kinds of basal insulins, how they're different?
Correct.
Yeah. So
And,
that,
and how they're absorbed and
Yeah.
more consistent, because there is day-to-day variation within
yeah,
the basals.
I think there's, you know, good evidence that there are better basals than not, particularly for hypoglycemic risk. So it's, you know, just a question of, and you know, the other new technology that I didn't talk about is obviously now pens that deliver insulin becoming smart pens. So where they can record how much is given, when it was given, so you can get better data, and maybe in the future being linked with a CGM right somewhere, you know, remotely, so that you can get all the data laid out together and then do some advanced analytics. But there are definitely some basal insulins. I mean, we all think of NPH for the type 2. I think most endocrinologists are past NPH other than the cost issue. You know, we were kind of, I think, in the US probably getting close to eliminating NPH until the cost of insulin got to be so much. And now, you know, papers suggesting that the marginal difference, you know, from a cost perspective across a broad population may not be that significant. We need to go back to NPH. I kind of hate to see that world because it doesn't make a lot of sense to me, particularly when we've got some basal insulins that look like they're better protecting from hypoglycemia. You know, but the next is to look at the pen, get better data from the pen, put the basal and bolus pens together, and then link them with a CGM and be able to apply some of these advanced learning AI analytics to those systems as well.
Thank you.
Yes.
So you're preaching to the choir here. It is easy to see that continuous glucose monitoring is a superior way to monitor and potentially administer insulin. As a clinician, can I order continuous glucose monitoring on every one of my patients, or what are the barriers that still exist for carriers and insurance companies that I have to get over before I can get treatment authorization for a continuous monitor?
So there are barriers. So there are some systems that some of the payers don't pay for. You know, and there are some systems that now the payers, that this is a preferred one, so they've already kind of, so you would probably need to look at who the payer is. Medicaid doesn't even pay for them in type 1 diabetes, so chances of getting them with type 2 is pretty close to negligible. Medicare is paying for those that don't have to have a finger stick confirmation, which right now is only the Dexcom and the Libre. But I think it's the payment level is kind of low, so there's some pushback there. But there are definitely payer barriers to the use of CGM. And even in type 1, there's kind of a medical necessity form where you have to kind of put all this kind of happen, and that's why I need a CGM. and then there may be some denial, so then you're back to whether the provider will go through whatever is necessary to get it covered.